Hi. Hi, Steve. Can you hear me?
Hello.
Oh, maybe I'm muted. Hang on.
Hi,
One
Dr.
moment,
Pipe.
please.
Hello.
Okay.
All right.
Randy, I can hear you.
I can't hear myself.
Dr. Pipe, can you hear Randy?
I can hear him fine.
This looks stupid.
Okay, Randy, Dr. Pipe can hear you.
What am I doing wrong?
You want me to come over there?
You guys can hear me, right?
Yeah, we can hear you. There's a little delay.
Okay. Let me get one of those AV guys so that we can make sure
Yeah.
you hear on the big screen.
Yeah, okay. Dr. Pipe, do you mind if we record this or should we not record it?
No, it's perfectly fine.
Okay, all right.
You will have to give me screen share.
You got it. Okay. Beautiful.
Yeah, I'm gonna do one slightly different. Just a minute.
Yep.
I gotta change you.
Did they have it already? You met our board member, Robert?
Oh, Robert, how you doing?
This is
yes,
Ashley.
we've talked on the phone and emailed. Yeah.
Ash,
Yeah.
self-infusions.
Oh, there you go.
Annabelle said she could speed it up.
When is that training?
Oh, that's
Even though you
amazing.
can't hear me and we can't hear you, I've got the
I can hear you,
tech guy coming.
Randy.
Jesse,
Randy,
who
we can hear you.
doesn't know much more than I do. Maybe I got something
In the
goofy.
patio.
No,
Anyway, there's a ton of people
he's
here,
having
Steve. I'll
problems.
tell you
He's got
that.
Jesse helping him.
Wait. One
Dr.
moment,
Pipe
please.
is good.
Okay, so you're gonna want to kill your speaker off. So if
There
you
we are.
just,
And I can hear Ashley too.
yep, that's all you
Steve,
need.
you there?
Okay.
But you don't need to.
Okay.
Here, Randy.
Okay, good. I can hear you.
Self-infusion.
We can't hear you up there yet.
Okay, so Ash, I'm gonna, Randy and Dr. Piper, I'm not sure about, so Rosie can do it in 45 minutes. Annabelle can definitely do it in
Okay,
45 minutes. So we're gonna
awesome.
go for 45 minutes. I'm gonna try and
It-
gather everybody else. and then-
It's
Okay, thank you.
We haven't done an in-person event in 4 years. And it's a
Hey,
little.
are you guys okay?
No, we can't hear, I mean, other than my little laptop, we can't hear Dr. Pike.
Oh, is Jesse coming to help you?
He is.
So your laptop is plugged into a sound feed.
Well, I can see the, it's just a,
Fumes, Randy, I'm like, my blood sugar starts to drop and I get a headache and I'm like,
No.
I need to like,
Gotta take care of you,
oh, yeah.
no.
My tech, my tech
He's the
support
tech
guy's got
person.
diabetes, so we gotta throw some food in his mouth. So here we go. So I can get sound here, and I can get video here, and I can get video up there, okay?
You might have
But
to change the sound output from your laptop.
The thing is, I don't think. I see what you're saying. No, it's all in one HDMI. Yeah, you want me to try it?
yeah. It's all one, just, it's not like it's got audio.
No,
jacks.
I understand what you're saying, yes. So can I minimize this?
Yeah.
Well, maybe there could be sessions about that.
Well, I could have just went here.
Just sessions that, just at some
It
point.
doesn't have that,
Good.
yeah, there should be some settings here. Go
Yeah, maybe I have to get into settings. Let me go into settings and see if I can.
to. You know what I'm talking about, right? Because
I know
usually
settings.
it gets you to toggle back and forth between, oh, sorry.
No
Between,
problem. Got to get into settings. Settings,
Sound.
sound, systems.
I know somebody, I just saw.
Sound.
Significant.
Sound.
It's weird. She said, all of
All right. Input, output. We'll check speakers. Wait, 1 moment, please. It doesn't give me any options. That's input.
You should, because remember when you click on the volume, the property, it would say, you want to use a headphone?
Randy, some HDMIs don't carry sound output. Depends on your particular laptop.
Oh,
I'm afraid that might be our problem.
Do you have like a like an 1/8 inch output from your laptop that could connect to the sound there or not? Or do you have like a Bluetooth speaker or something?
no, we don't.
Well, it's in a room that's got.
Oh, do they have? Oh, sorry. Here, let me get my.
Is that audio?
But I got that adapter. If this is, if we're able to do it, I got an adapter. Oh, okay.
Does it say audio?
Yes, it does. I got the cables for you. I got the cables.
Like it's like a
Yeah, yeah.
Well, does this thing have a hole
Yeah, right
for
there.
it?
Right there. Right here.
Okay.
Okay, let me grab that for you.
All right.
Let me grab my bag.
All right. Thank you. Take some while you eat while you're
No,
moving.
I'm good. I'm good. I'll leave it right there.
All right.
You're doing this session, Randy?
Yeah.
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 What about Dr. Pike?
He's on the line.
Cool.
All right. So luckily, we have a technical guy who has a bag of tricks, and he's going to get a cable,
Excellent.
which plugs into the headphone jack of my laptop.
Right.
And there's actually a hole on the wall here that says audio.
All right. Well, that might
Which-
work.
And when it's better than zip.
Did it work? Did you guys do it work?
Nope, not yet. I mean, I can see Dr. Pipe, but we need to get audio. There's a hole here and there's a hole there. And if we got a cable, we might be able to make that work.
Oh, I get it.
Yeah, but so when I went to the settings to try and change the output, it only gave me one choice, which was my local speakers.
Oh, yeah.
Look at that bag of stuff.
I got all kinds of different cables and wires.
It's not RCA.
No.
It's like a regular person. Ain't gonna have a break. They can't have it.
They can get a hold of an actual AV guy. They had AV guys here.
He's over there. The other lady, she was pulling me over there. I said, I'm helping Randy. I'll be right there. Yeah, go ahead. Very talking to guy, James. They don't have any kind of cables, but my cable. All we need is I have one here. What time are you getting started right now?
Yeah.
I got an adapter for this. I'm taking it here.
No.
This works, I promise.
Okay, I have. Oh.
Test 1 2 3 1 2 3. Test 1 2 3. And get the thumbs up.
All right. All right, thank you. Good. I am totally good. You saved the day. Thank you, thank you. I think that's okay.
I think they started late.
All right.
Yeah, but it's so good to see you.
I will, I definitely will. Got about 25 people here, plus an interpreter. All right, I'm gonna go call out, say last call. Okay.
Okay.
So here's the deal. This session, we're not doing. Okay?
Oh, because I could hear Randy and those guys over there, yeah.
Yep, but, because it's on my laptop.
Gotcha.
Ash.
But we're not doing
Ash,
this session.
Okay. Tell me.
Ash.
We're doing this session, and it, for some reason, it's
Okay,
not
let's
coming
try
up
it.
there. Yeah. Thank you.
Ash, you got a mic, you gotta block your mic. Ashley.
The mic, they can hear us. Can you make it so they can't hear us?
Just mute this thing to me. Here we go. So we got video.
We don't need it yet, so you're fine.
Okay, so let's go to your settings, which. Where are my
Here we go. Here we go.
Okay, go to your volume. Go to your volume. You know your machine better than
I don't
sound.
see it.
Your sound right there.
Oh,
So the speaker. I mean the. There you go. You're good. You should be good now.
wait, input.
Yeah. There you go.
Okay, she's done. Good. All right. All right, thank you very much. I'm gonna get up here in front. Steve, I'll be with you in just a second.
I am here.
Okay. So, Dr. Steve Pike is a professor in Lawrence A. Boxer, research professor of pediatrics and professor of pathology at the University of Michigan, Ann Arbor, Michigan, USA. He has served on the board of directors for the Hemostasis and Thrombosis Research Society, otherwise known as HTRS, as chair of the board of directors for the American Thrombosis and Hemostasis Network, also known as and most recently as the chair of the Medical and Scientific Advisory Council of the National Hemophilia Foundation, also known as NASAN. And for those of you that aren't aware of this, these three organizations that he's being the chair of are the people that make all the policies on care and of bleeding disorders in the country. So he's got quite a pedigree, and he's a nice guy. So I'm going to put it right there. I don't know if you heard that stellar introduction, but I did a good job. All right, take it away.
Okay. Well, good morning, everyone. Randy, if you want to give me a thumbs up if the sound's okay for everybody there. Excellent. Okay. Well, I'm really glad to have the opportunity to talk to you today. I'm going to give you a brief overview of new therapies for hemophilia. Can even think of these as emerging therapies because most of what I'm going to talk to you about is still not a reality from ability to treat patients clinically yet. However, there's a number of clinical trials that I think are really interesting and may be options for people in the future. And what we're going to spend time doing is These new therapies in many ways involve completely novel ways of promoting blood clotting. So my aim is also to help you understand how they work, what the potential benefits are, but then also I want you to be aware of what risks these new therapies may offer as well. These are just my disclosures. I have consulted for a number of these development programs, but I don't have any personal stake on whether they come to fruition or not. So the objectives here, we want to help you understand, what are the current standards of care for management of hemophilia. I want you to understand what some of the benefits, but also the limitations of the current therapeutics, and why we should be looking for ways to further optimize the care for patients with hemophilia. And then we're going to just discuss how novel therapeutics, including non-factor replacement therapies and gene therapy, may improve outcomes for patients with hemophilia down the line. So the goals of modern hemophilia treatment include the ability to treat bleeds, the ability to avoid bleeds, and to avoid the complications from particularly repeated bleeding. We want to avoid joint disease and enable patients to achieve the life that they choose. And for decades, we've relied on factor replacement therapy to strive to achieve these goals. Now, to help you understand why there's still unmet needs here in helping to meet these goals, we need to put a little bit of effort into the background of the current state that we're in and why we do need some additional improvement. So it's always a good place to start to understand what's really going on when bleeding occurs into a joint. This is the primary manifestation of hemophilia, is bleeding into joints. And so what's being depicted on the left schematic figure here is a normal, healthy joint. And let me see if I can get a pointer here. I think this will work. Hopefully you guys can see this pointer on the screen. So imagine that this is a knee. So on this half is the normal healthy side. So this is the bone, of course, and this is the joint space. And you see the cartilage in blue, all healthy and intact. There's a fibrous capsule on the outside of the joint. And this is actually where the nerves are. There's no nerves on the inside of the joint. The nerves are all in this fibrous capsule. And then what's not really shown here is a very thin layer called the synovium, which we'll talk about in a couple of minutes. Now, in hemophilia, when bleeding occurs into a joint, this begins to fill the joint space. And the first thing it does is it stretches the inside of that joint space and it puts pressure on that fibrous capsule. Remember, that's where the nerves are. And that's actually why you get pain when you bleed into a joint, is from that pressure inside the joint. But furthermore, blood acts as an irritant. It causes inflammation. Why does it do that? It's because the breakdown products from the blood that ends up in the joint actually drive a signaling in the cells inside the joint space to drive an inflammatory response. When you think inflammation, think heat and think pain and think swelling. And the synovium, that normally thin lining, which is relatively avascular, which means it doesn't have a lot of blood vessels in it, its job is to resorb that blood and get it out of the joint. Now, when you treat for a bleed, you can stop the bleed in some short order, hopefully within, a couple of hours or so. But that blood doesn't have anywhere to go. And so the synovium's job is to basically absorb those blood components and take it back into the bloodstream. Now, the breakdown products from the blood, however, continue to drive an inflammatory reaction. And that inflammation leads to a number of things. It starts to break down the cartilage. The inflammation can also change the bone remodeling, and so that you start to get bony changes. And then worse, the synovium, in response to the blood in there, starts to thicken. It undergoes what's called hypertrophy, which means it gets thicker. And it also starts to form these almost like fronds. So think of like a sea anemone. And so this joint can get filled with all of that enlarged synovium. And unfortunately, what happens is when the synovium enlarges, it accumulates more blood vessels in the synovium, which means you're even more likely to bleed the next time. So what we end up with is this vicious circle of bleeding, iron deposition from the blood, inflammation, hypertrophy, neovascularization is that new blood vessel formation, and then further bleeding. And the only way to get us out of this cycle is to prevent bleeding. Otherwise, we end up with these boggy, inflamed joints, and then with progressive osteochondral, which means cartilage and bony degeneration, we can end up with severe joint debility and contractures. So this is what we're trying to prevent over here. So some of you may be familiar with factor levels that we use to assign severity in hemophilia. So this is a study from the Netherlands in patients who have all different severities of hemophilia. And if you have severe hemophilia, you have less than 1% activity. If you have moderate, you have 1 up to about 5% of activity. And if you have mild hemophilia, you're above 5%. Now, this is on this graph, it's looking at people whose residual factor level based on their severity, according to what's the typical number of joint bleeds that might be expected over the course of a year. And as you would expect, patients who have less than 1% have the most risk for a joint bleed. But even having as little as 1 to 3% levels, you can actually have a significant drop off in the risk for joint bleeding. And if you get above 5% in the mild hemophilia range, that goes down even further. And there's some threshold, maybe around 12 to 15%, where it's very unusual to have any joint bleeding, even really with trauma. And so what's come with this is these have now become the targets for prophylactic therapy with factor replacement. When you give factor, you're trying to maintain a trough level right before that next dose that keeps you in a range where you should reduce your risk of bleeding. Traditional prophylaxis for decades had targeted sort of a level between 1 to 3%. We now know that optimizing prophylaxis is better if we can get people to keep trough levels of between 3 to 5%. And there's a new standard of care is that we really want to be able to get people who are well into this mild range where their risk of bleeding would be almost eliminating. Aspirationally, we can't get there yet, at least with traditional replacement therapies. It would be nice to keep people so they never dropped even below 15 to 20%, and that might completely eliminate joint bleeding. Well, how well are we doing with traditional factor replacement? So we got some insights from this from a study called the U.S. Joint Outcome Study. Now, this was done and started more than 20 years ago. And what they did is they enrolled toddlers and got them on prophylaxis early before they had any evidence of joint disease. And they put them on regular traditional prophylaxis. And then they followed them till age 6, so on average about 4 to 5 years. And what they did is they looked at MRI. So remember, this is a way to look at joint structures with a scanner. And they examined the target or the index joints in the study were the elbows, the knees, and the ankles. And what they saw was that they saw changes in joints that the parents swore had never had any history of bleeding into them. And this is consistent with some background of microbleeding occurring into these joints. We have long-term follow-up on those patients that I'll show you in a minute. But what the punchline is from the study is that early prophylaxis was not sufficient to fully prevent joint damage in all patients or all joints. There was another study called the Canadian Dose Escalation Profi study. What they did is they started young boys on prophylaxis at once per week, then they escalated to twice per week or to 3 times a week or every other day, based on whether they were having breakthrough bleeding. And a similar story was told from this study when they did MRI evaluation of the joints of these boys when they were in school age. What they found is that they were seeing changes in the index joints, remember, elbows, knees, ankles, even though those joints had never any history of any overt clinically reported bleeding. And consistent with the pathology that I just walked you through a couple of minutes ago, this heme, this iron deposition, it's a breakdown product from the blood in the joint. It was seen in a quarter of joints that had no record of ever having bleeding into them. So this tells us that traditional factor replacement isn't getting us as far along as we had hoped. Now, what happened to those boys after they exited the original study at age 6? Well, this is their status of their joints when they were age 6. There was 32 of them that were on prophylaxis, and they were compared to a group of boys who were not treated with prophylaxis. They were just on episodic or on-demand therapy. And at age 6, 93% of the boys on early prophylaxis had no evidence of any bone or cartilage damage, whereas just barely over half of the boys who were on episodic prophylaxis. Well, at the end of year 6, they saw the improvements from prophylaxis. So all the boys at age 6 were shifted to prophylaxis. So we'll call them late prophylaxis. So they weren't on early, but they were put on prophylaxis from age 6 onwards. But disappointingly, the boys at age 6 who had this degree of joint preservation, now only by age 18, which is the end of this current study, now only 2/3 of those boys are showing no evidence of joint damage. And that drops to 24% of the boys who were shifted to late prophylaxis who still had no evidence of joint disease. So this suggests that there's a trajectory of continued joint deterioration. It's slower, but it's not arrested from prophylaxis. We get some insights too from a study that Randy Curtis and his colleagues had published a few years ago. This is the HUGS 5 study. This looked at, it was 2 prospective multi-center studies. It recruited 141 boys and men between age 18 to 34 within the hemophilia treatment centers across 11 states. 103 had hemophilia A, 38 with hemophilia B, and 2/3 of them had severe disease. Now, these boys were grew up in an area where they would have benefited from the application of standard of care prophylaxis through early childhood and adolescence. Yet, as young adults, a significant proportion of them reported joint pain either some of the time or most of the time. And some even complained of having severe pain all of the time. And only less than 10% of them reported that they had no limitation in motion in their joints. So again, this is a disappointing outcome. It tells us that the traditional standard of care prophylaxis hasn't got us as far as we needed to do to fully preserve joints in older individuals. So the future treatments should aim to address some of these unmet needs for people with hemophilia. So breakthrough bleeds and a trajectory of continued joint health deterioration remains a feature of current prophylactic therapies. So we really can look forward to future treatments that can deliver 0 bleeds over the course of a year, particularly into joints. We would like to see easier and less frequent administration of these therapeutics, and this will relieve the treatment burden for patients. We want to look towards therapies that can provide efficacy in persons who have hemophilia, regardless of whether they have developed inhibitors. We shouldn't leave our patients who have inhibitors behind. We should be able to have treatments that allow them to have the same outcomes as patients who don't develop inhibitors. We're striving to help persons with hemophilia achieve an improved quality of life, including living active lives that are similar to their unaffected peers. And ultimately, we want to seek accessible treatment for all persons with hemophilia as well. So prophylaxis with factor replacement products is still considered the standard of care for all people with severe bleeding phenotypes. And this is where we give regular administration of these therapeutic proteins that's aimed at maintaining hemostasis or blood clotting. And this is now the standard recommendation over so-called on-demand therapy. And this has allowed for prevention of bleeding and especially prevention of joint hemorrhages. And it's enabled persons with hemophilia to really start to live healthy and active lives that's becoming similar to the non-hemophilic population, with the caveats that we've just talked about. So what is it that we have available to us for factor replacement? Well, originally it was plasma-derived clotting factor concentrates. Then we had the recombinant era. And within the recombinants, we can apply different bioengineering techniques that have improved the performance of these molecules and how long they last in circulation, the so-called half-life. So now we sort of think of recombinants in the standard half-life, which is the original ones, and then the extended half-lives that have a little bit longer action in the bloodstream. Now, if you have an inhibitor, you can't use these replacement therapies. And so for breakthrough bleed treatment, you have to rely on either recombinant factor 7A or activated prothrombin complex concentrate. So there's really only one approved for each of these in the US. This is Nova 7 and this is FIBA. And this can be used for people with hemophilia A and B with inhibitors. The newest treatment that's become available is something that mimics the action of factor 8, which means it can only work in hemophilia A. But because it's not factor 8, it's not, its action is not blocked by inhibitors to factor 8. So this is indicated for patients who have hemophilia A with and without inhibitors. And it has become one of the, if not the most dominant prescribed therapy for prophylaxis in the US now. So I'm going to introduce you to this concept of rebalancing the clotting system. This helps explain bleeding. It also helps explain what we're doing with these new therapies, and it also will help you understand how these non-factor therapies could possibly work. So factor replacement therapies rebalance blood clotting or hemostasis by replacing something that's missing. We call those the procoagulants. This is factor 8 or factor 9. So think of this teeter-totter. You have a balance of your pro-clotting factors on one side. That includes factor 8 and factor 9. And then you have these natural, what are called anticoagulants or inhibitors in your blood plasma that counteract that activity. Now, normally we should be in a balance like this, good number of procoagulants and anticoagulants. Well, but when you have hemophilia, you're missing a key procoagulant, either factor 8 or factor 9. And so the balance shifts. And so you have bleeding. When you give yourself factor or factor 9, you then rebalance your blood clotting and bring it back into focus. Well, the trouble is with these proteins, when we infuse them, sure, we get this big peak right after we infuse it, but within minutes and hours afterwards, the level in our blood plasma starts to fall precipitously, and eventually it's going to fall to quite low levels right before you're due for your next infusion. So this is a typical infusion strategy: Monday, Wednesday, Friday, Sunday, so 3 days a week. What you can see is right before those next infusions, the factor level falls below critical thresholds. And this may be a window when breakthrough bleeding, including joint bleeding, can occur. Well, what happens when we use an extended half-life? Well, yes, it extends how long the blood or the protein will stay in the blood plasma, but it's still going to fall to low levels. And patients can still spend a considerable amount of time below those critical levels. And that's probably contributes to the bleeding risk that we see on factor replacement therapy. Well, another way to use the extended half-life or the long-acting factors is to keep the interval the same. But because of the properties of its extended half-life, this keeps your levels at a much higher range. And this is what we've been doing at our center for a number of years now. We may still use this Monday, Wednesday, Friday, or every other day, but not everybody needs that compressed of a schedule. But the long-acting factors have allowed us to keep higher trough levels, and this has contributed to improved outcomes for patients. we have some real world data now, because the long acting factor 9s, this is one study from a long acting factor 9 that's been available now for 5 years. And what was seen is this is from Dr. Shapiro's clinic at Indianapolis. And she looked at the bleeding rates in the patients before and after they switched over from regular factor 9 to the long-acting factor 9. And they saw a dramatic reduction in, this is the annualized bleeding rate, so all bleeds. This is spontaneous bleeding rates, and this is joint bleeding rates. And each one saw significant improvement after they switched to the long-acting factor 9. When they looked at the reasons why the patients switched to that long-acting factor, they said because it was a reduced treatment burden, they weren't getting the kind of efficacy or outcome from their previous treatment, and it helped because some of them had difficult venous access, or they were struggling to maintain adherence to the demanding regimen. What about for factor 8 though? Well, the factor 9 products work, the extended half-life ones are really, really effective in that they extend the half-life about 3 to 5 fold. So you can easily go from needing every other day or 2-3 times a week to once every week, maybe once every 2 weeks in some individuals. For factor 8, it hasn't been that as good. And this is all the different extended half-lives that have been approved in the US for use. Compared to the traditional factor 8 half-life of about 10 to 12 hours, these are all between 14 to 19 hours. So they're only about 50% longer than the traditional factors. And we now understand why that's the case. And that is because factor 8 doesn't circulate on its own like factor 9 does. It's bound to its carrier, its stabilizer in plasma, which is called von Willebrand factor. Well, if factor 8 is always bound to von Willebrand factor, it can't have a longer half-life than von Willebrand does. So that creates a ceiling, and it sort of sets the ceiling for how long factor 8 half-life could be. The only way to get really long half-lives of factor 8 would be to decouple it from binding to von Willebrand factor and get rid of this ceiling that's imposed by binding to von Willebrand factor. Well, we now have a therapy that's in late clinical trials that has been able to do that. And this is a really elegant molecule. This is what factor 8 looks like in the blue. There's a product on the market called Aloctate, which uses something called an FC fusion. This is a fragment from an immunoglobulin or antibody, adding that conjugate onto factor 8 already extends its half-life. Well, then what they did is they took not a full von Willebrand factor, but a fragment of von Willebrand factor, and they fused that to the factor. So it's coupled together. That's what stabilizes it in the plasma. And then on top of that, they added these protein elements, which are called extend sequences. And what that does is it buffers the protein away from clearance receptors. And with the combination of these additions to factor 8, they ended up with a molecule that has a very long half-life, and it's decoupled from von Willebrand factor. When it gets activated, it looks exactly like the activated factor that comes, that's normally infused in the form of Aloctate or recombinant factor 8 FC. So these elements don't interfere with the blood clotting. So how does this work? Well, on this graph on the left, here's the peak right after an infusion of giving traditional standard half-life factor 8. And you can see how quickly the level falls below 50%, below 10%, and down approaching, towards 1% after about 72 hours. Well, what happens when we give this, what's called BIV001, which is that includes all those modifications? We see that it significantly slows down the clearance from the blood. So now with a single infusion, patients are staying in the normal range for most of the week, actually. By day 5 is the first time they're even falling back into the sort of hemophilic range. And they can maintain levels above 10% for at least a week. And so this is giving us promise that we might now have in the future a once-a-week factor 8 therapy that would help overcome some of the prior challenges. Now, we mentioned that inhibitors have complicated factor replacement therapy. This occurs in about 30% of people with severe hemophilia A. So this is not an insignificant problem. We usually see it very early with their first exposures to factor VIII. It occurs significantly less often in factor IX. We don't totally understand why that's the case, but only about 5% or less of people with severe hemophilia develop inhibitors. But when it does happen in factor IX, it's really life-changing. So the consequences here, this can cause serious complications such as uncontrolled bleeding because you can no longer use factor VIII or factor IX. It contributes to advancement of joint disease and to disability. And we know that inhibitors are associated with a higher disease burden, more serious bleeding complications, more allergic reactions to their infusion products, higher rates of hospitalization, cost tremendously more for management, and unfortunately, even higher mortality rates. Now, the agents, since we can't use factor VIII or factor IX, we use what are called bypassing agents, FIBA, Novo-7, or APCCs, and recombinant 7A. Now, do these fit in our model that I showed you before of rebalancing the hemostasis? Well, it does. Because now instead of rebalancing the procoagulants by giving factor VIII or factor IX, these are still procoagulants, and they do rebalance, or at least move towards rebalancing through infusion of these products. And so it still fits our model. What about emicizumab? How does this work? Well, I mentioned that it's not factor VIII, but it mimics factor VIII, which means it still acts on this so-called procoagulant side. So what it does as a prophylactic therapy, it brings the blood clotting system back towards a balance, and it restores blood clotting. Now, the only trouble with this therapy is it's only a prophylactic therapy. And so giving more of it in the context of a breakthrough bleed doesn't work. So we use it for prophylaxis. We still have to rely on factor or bypassing agents, depending on whether you have an inhibitor, to rebalance when you have a breakthrough bleed. Now, how effective is this treatment? Well, it seems to be highly effective. This is looking at, again, annualized bleed rates in patients before and after they got switched to emicizumab. And this is across a number of different clinical trials. Haven 1 was adolescents and adults with inhibitors. Haven 2 was pediatric patients under age 12 that had an inhibitor. Haven 3 were non-inhibitor patients with hemophilia A, and Haven 4 was a mixture of inhibitors and non-inhibitors that looked at every 4-week dosing. So remember, the dosing maintenance schedule for emicizumab is either once a week subcutaneous injection, every 2 weeks, or every 4 weeks. And no matter what regimen was used, you can see that their annualized bleed rates drop and stay improved across weeks and weeks and weeks. And this is following patients for more than 2 years after the switch to emicizumab, and they maintained very good control from joint bleeding throughout the follow-up, and for some patients as long as 4 years in the clinical trial program. If we look at the percentage of participants who experienced 0 treated bleeds over this increased in the first year after they went on emicizumab, and it remained above 80% thereafter. So these are looking at 6-month intervals over, up to 4 years. And you can see that the percentage of patients who have 0 bleeds is just above 80%. And if we include those who only had 1 to 3 treated bleeds in those window of time, now we're upwards to 90–95% of the patients. Haven 4, I mentioned, is the every 4-week dosing. When you think of going from every other week intensity prophylaxis with factor replacement, now we're giving a subcutaneous treatment every 4 weeks. Well, these patients also maintain meaningful control of bleeding, whether or not they had an inhibitor. Here, more than half of patients had 0 treated bleeds. 83% had protection from spontaneous treated bleeds. More than 70% had 0 treated joint bleeds, and 85% reported 0 treated target joint bleeding. The reason for this improved outcomes is probably related to the steady level. Now, if you remember those curves I showed you were factor replacement, there was a peak and then it falls off to a low level trough right before the next dose. That doesn't happen with emicizumab. There is a loading phase to get you up to the maintenance range, but then whether you are dosed once a week, every 2 weeks, or every 4 weeks, you maintain sort of a steady level 7 days a week, 24 hours a day, 365 days a year, you stay up in this maintenance range. And we think that that contributes to the enhanced outcomes for patients for protection from bleeding. And this was observed both for adults and pediatric patients. What other benefits can we see? Well, you may be familiar with quality of life tools. These are questionnaires that people are asked about their physical health. Clinically meaningful improvements were observed in this particular physical health quality of life tool. And this was observed in more than 44% of adult patients with hemophilia A without inhibitors who were placed on emicizumab prophylaxis. They reported fewer missed days of work. And if you look here, only 76% of them at baseline reported having 0 missed days of work, but that went up to more than 90% after they switched to emicizumab prophylaxis, and that was sustained over almost 2 years. This is the improvement. So these lower numbers indicate improvement in this quality of life tool. And then if you ask the patients, well, how did they prefer emicizumab over their previous factor VIII replacement? Well, absolutely. 94% preferred it over factor VIII replacement. 98% favored it over their prior factor VIII prophylaxis. And 100% of these in this study chose to continue emicizumab after they had been on for 24 weeks of treatment or 6 months. Okay, so let's summarize again. This is a different way of thinking about this rebalance. So on the left here, we have the procoagulants. These are trying to drive clotting. These are the proteins in our blood which are function to rebalance on the natural anticoagulant side. So if we're in a good balance, we make lots of thrombin when our blood needs to clot, and this converts fibrinogen to fibrin. That's how we get a good clot. Well, what happens when we're out of balance? If we're missing factor VIII or factor IX, we're losing the balance. All of these proteins are still in full function. And so they're counterbalancing this deficiency over here, and that's going to tip towards bleeding. We're not going to be able to generate thrombin properly, and we're not going to be able to convert fibrinogen to fibrin. So the current conventional treatment approaches, whether that's factor replacement therapy, factor VIII mimetics like emicizumab, these all aim to restore blood clotting by acting on the procoagulant side of the balance. But alternative approaches are currently being investigated in the investigative pipeline. So let me walk you through a few of these, okay? So here we're out of balance. We're missing factor VIII or factor IX, or we have an inhibitor to factor VIII or factor IX. What if we didn't add a new procoagulant over here, but we targeted the anticoagulants and we either eliminated them or counteracted their function or dropped their levels in the plasma? We could rebalance here, even though we've not given any factor VIII or factor IX or a bypassing agent. So does this work? Absolutely. So the targets here are those targets I showed on the other screen: activated protein C, antithrombin, and what's called tissue factor pathway inhibitor. In the pipeline therapies, we have programs that target each of these natural anticoagulants. Fatuzaran is a subcutaneous injectable that lowers antithrombin levels. Serpin-PC just entered clinical trials, and it targets compound called activated protein C. And there's been 2 other antibodies, concizumab and marstezumab, both which can be given through subcutaneous injection. And these target the other anticoagulant called tissue factor pathway inhibitor. And they all seek to rebalance by this same mechanism. Now, what's common to all of these is they work great as preventative agents or prophylactic agents. But if you need to treat a breakthrough bleed, you have to give either factor VIII, factor IX, or a bypassing agent. Well, can you see what the problem would be? If you've already knocked down these anticoagulants and brought blood clotting back into balance, what would happen if you added a procoagulant on the other side? The risk is if you used too much or too aggressively, you would tip the other direction and you could end up with blood clotting. And that's where we're still trying to work that out in the clinical trials. So let's review the concepts we've covered so far. This is with focus on the non-factor replacement therapies. They're effective in prophylaxis, but they still require some use of another hemostatic agent if you have a breakthrough bleed or if you needed surgery. They're effective in both hemophilia A or B. Remember, since we're acting on the other side of the balance, it doesn't matter whether you have hemophilia A, whether you have hemophilia B, or whether you have an inhibitor, they're all going to work the same. So they're cross segment, we say. And this may increase the number of treatment options available to persons with hemophilia A and B, whether or not they have an inhibitor. There's no peaks and troughs with these agents, really. And so we're getting rid of not having stable correction of blood clotting between the doses. For the most part, they're all given subcutaneously, so that reduces the burden of having to find an IV. And the frequency is generally lower than if you were having to rely on factor replacement therapy or bypassing agents. Well, what about gene therapy? Well, gene therapy also can provide a way to think about this model we've talked about. So what we're doing here, though, to enhance the procoagulant side that's defective when you have hemophilia, we're not giving a protein anymore, like a factor, but we're giving the gene that codes for that factor. So the gene for factor VIII or factor IX is delivered to some cell in the body that has the capability to make factor VIII or factor IX. And as those levels accumulate in the plasma, it rebalances the clotting system again and brings things back into a balance. So be effective protection agent. So how have we sought to do this in hemophilia? So this is the general approach to walk you through. So we need the gene for factor VIII or factor IX. We need some way to deliver it, and we've chosen the liver because the liver seems to be capable of making clotting proteins really well. The liver makes almost all the clotting factors in our blood anyways. So what happens is we need a delivery vehicle. And so what we do is we use these non-pathogenic virus vectors. So these are not viruses like you would think of them. This category of adeno-associated virus is a naturally occurring virus that we encounter in the community. It doesn't cause any disease in humans, but many of us have been exposed to them before. But what their feature is that they can nicely have their viral genes eliminated, and we can just use the protein shell of the virus and package in there the gene for factor VIII or factor IX. And then the other elements that we add in here, once the virus homes to the liver, we want to make sure that the genes only get turned on in the liver cells. And if the virus ends up in any other cell of the body, it basically will do nothing. So there are elements in the gene here that allow it to only be expressed in the liver. So these are packaged. Now, to get efficient delivery to the liver, this is trillions and even quadrillions of these viral particles that are put together. They're delivered in a single treatment event. This is an IV infusion, goes in with an infusion pump over about 1 to 3 hours in the outpatient setting. The viral vectors target the cells in the liver, which are called the hepatocytes. And once it gets into the cell, there are receptors at the liver which will take up this viral vector inside the cell, and then it goes to the nucleus of cell. If you remember, that's where your genes are held inside the cell. It delivers the payload, that factor VIII or factor IX gene, into the nucleus. And once it's inside the nucleus, you have the normal machinery of inside the brain of the cell. It reads that code and it says, oh, we should make factor VIII or we should make factor IX proteins, and it starts to make them and then secrete them into blood. And what you end up with is a steady state of expression from the cell and then the normal clearance of factor VIII or factor IX. And then we measure that level in your blood plasma. So this is a relatively simple concept, but there's a couple of hurdles here. I mentioned to you that we have all been exposed, likely, at least by adulthood, to some variant of adeno-associated virus in the community. And it's possible that you have developed antibodies against AAV. And if those antibody levels are high enough, if we tried to give you this AAV vector, those antibodies would basically bind to this, cancel it out, and block it from uptake into the liver. And so it would mean that the treatment wouldn't work. So what we do in almost all the clinical trials is we screen people with a simple blood test. And if their antibody levels are too high, we can't actually use this mode of therapy. There's one clinical trial that was able to still get good expression. This is a treatment for factor IX or hemophilia B, but essentially all other therapies have had to exclude patients who have these neutralizing antibodies. The second hurdle here is once the vector has delivered the gene to the cell, it has to do something with this empty box. So I like to think of this as Amazon boxes. This is the package you want to have. It gets packaged inside here into the delivery vehicle. It's delivered to the house here in the hepatocyte. And once you take it inside the house, of course, you take out the contents of the package, but then you have to recycle the box. And when your body recycles this protein coat, unfortunately, it presents those proteins to the immune system. And the immune system sees those proteins and says, that's not a self protein. That's a foreign protein. And so it starts to make antibodies or other immune responses. And those immune responses can lead to liver injury or liver inflammation. And the way that shows up is elevations of what are called liver enzymes. Again, simple blood tests that we can measure. And this happens in a high proportion of patients who participate in gene therapy. It's completely asymptomatic. You would not know anything is going on if we didn't measure the blood tests. But if we see this observed in the blood, we assume that there's an immune response going on, and we put people on a course of immunosuppression using oral corticosteroids or prednisone. Some of you may have been exposed to prednisone before for different things to reduce inflammation in joints. Some people who have a history of asthma will use prednisone routinely. But this seems to be effective in a good proportion of patients. It resolves the inflammation and the liver toxicity, and then you get sustained expression from that point forward. So who's actually been getting gene therapy? Well, only adults so far, mostly severe or a moderately severe disease. These are patients who are all well exposed to factor VIII or factor IX in the past. They can't have had even a history of inhibitor. If you had a history of an inhibitor, even as a young child, unfortunately, you've been excluded from the trials to date. There are a few other exclusions. I mentioned the neutralizing antibodies to the protein coat we call the capsid. And because we're targeting the liver, you have to have a healthy liver. So we do some screening tests at the point of enrollment to make sure your liver can take on this treatment and have a good outcome. Because we're treating adult patients, there's still the legacy of people who've had hepatitis B or C. And because of that, we need to make sure they don't have too advanced fibrosis or certainly cirrhosis. And we need to make sure they've gone through hepatitis C eradication with the antiviral treatment so that that won't pose a problem in the future. Not all of the trials have excluded HIV as long as the patient was under good control with their HIV meds. So what are the outcomes we've seen to date? Would be a story for another day to walk you through all the data with gene therapy, but here's the sort of punchlines. It is a single infusion event. Clinically relevant expression of factor VIII and factor IX has been achieved, potentially to within the normal range. Some clinical studies have shown that the durability of the expression has been at least 4 years in hemophilia A. It's now actually beyond that, and more than 8 years, actually beyond 10 years in hemophilia B. This has led to reduction of bleeding episodes, reduction of the need for prophylactic treatment, and improvements of quality of life. And importantly, those were directly compared in a couple of phase 3 trials, which are the late phase trials, against people who were on traditional factor replacement, and even better outcomes for patients after gene therapy than when they were on good standard of care factor replacement. What are the limitations? You can have a mild infusion reaction to the day of the infusion, but these are manageable. Hasn't led to any serious adverse events for people. There's a high variability in the levels that are achieved. I can't tell someone what level they're going to get when they go through gene therapy, whereas I can do that with a factor replacement. I can dial up any dose and get to the level I need. So that has been some cause of concern. And the second concern is there's no guarantee that those levels will be sustained over time. They seem to be stable in hemophilia B. We're not seeing the same stability in hemophilia A with a slow decrease over time. I mentioned the immune response to the protein. This seems to be short term. It's limited. It's responsive to immunosuppression in most patients. Mentioned that pre-existing AAV antibodies preclude you from participating in many of the trials. This is probably going to be a significantly high cost, but none have been approved to date, but that may also limit its availability worldwide. And the long-term durability of the treatment and the side effects are unknown. Now, I put on here this concept of integration. So I just want you to understand a little bit what's happening with AAV gene delivery. When that gene makes it to your nucleus, it stays outside of your chromosomes, which is where your normal genes lie. And it circularizes into this little piece of circular DNA called an episome. And that's how your machinery reads it and produces the factor VIII or factor IX. But at a very low rate, pieces of that DNA can actually integrate into your chromosomes. Well, does that cause a problem? Well, we wouldn't have brought this to the clinic if we thought there was any evidence that it caused long-term risk, including causing liver cancers or anything like that. It's never been observed in the trials to date. We have dogs that have been treated with these gene therapies that live to a ripe old age. Dogs can live 13 to 15 years. These dogs received this exact same treatments. None of them developed any liver pathology. None of them had any evidence of malignancy from this intervention. But we don't know. We haven't followed patients for decades and decades. So unfortunately, this becomes sort of an unknown risk that we either have to accept or at least weigh in the balance of what are the benefits that I might achieve on the left side panel here, and what risks am I willing to embrace until we know maybe some decades from now. And the last piece is because after you've received this virus vector, you're going to mount a really robust immune response. We don't see any way that you can get this treatment again. So if you were one of the unfortunate patients who lost expression over time or just didn't get a good outcome, unfortunately, it doesn't look like you'll be able to get this same treatment again. Does it mean you couldn't get another treatment? Well, no, not at all. In fact, what's happened with these patients, if they did lose expression over time, they just went back on their previous therapy. If it was factor replacement, that's fine. Some of them may have even gone back onto emicizumab, and they've done well as well. So there's nothing about receiving this treatment that would preclude you from embracing traditional standard of care replacement therapy afterwards. But just to be clear, we can't promise anyone that they can be redosed after the fact down the line. Are there other types of gene therapy coming that don't involve gene addition? Well, you will hear this term called gene editing. This is really a different approach. It still may use viral, but also non-viral approaches. But what happens is they can go into the cells, they can find the gene that was defective, and they can either insert a new gene into that spot or even edit the mutation and convert it back to a normal version of the gene. These are in very early stages. This has not been done in hemophilia outside of one trial, which was not pursued after the first handful of patients. But there is a new trial that's come back with sort of a better version, if you like, and that's going to be starting up either later this year or next year. And the nice thing about this treatment is it probably will produce a durable, definitive treatment and hopefully would not lose expression over time. So I've talked to you about a number of treatments here. What this graphic is sort of depicting here are the concentric circles of moving, how new therapies move towards the the clinic and to approval. From phase 1, which is very early, just handfuls of patients, phase 2 to prove whether it works or not. Phase 3 is the definitive pivotal trial that determines whether it's suitable to be submitted to the regulators. And then in green is the target, which is a marketed treatment. The new therapies we talked about today are factor VIII mimetics like emicizumab, which is the only one that's approved today. But notice here, there's a couple of competitors that are coming. These promise some improved potency maybe over emicizumab that might have some benefit. So these are working their way through the clinical trials. I mentioned these rebalancing therapies targeting activated protein C, TFPI, antithrombin. Some of these are still early stage, but others are pretty late in the process. And we hope to get readouts on these to determine whether these are going to be submitted for consideration for approval. And then we have all the gene therapies, some early, but some are quite late phase. And I can tell you at least one of these, which is this gene therapy for hemophilia A called Roctavian. This has been submitted to the regulators in Europe. It's under review. I anticipate it will be submitted to the FDA for consideration. And if it gets approved, that'll be the first gene therapy to sort of hit the mark here in the green. What the symbols are indicating is these can be indicated for hemophilia A or B with and without inhibitors. Those are the circles. Some cases, only hemophilia A with and without inhibitors. Other cases, only hemophilia A without inhibitors. And in some cases, only hemophilia B without inhibitors. So what I take from promise from this is we are improving the equity for patients because we've got pipeline therapies, which are offering some tremendous process, regardless of whether you have A or B with or without inhibitors. So I'm going to leave you with this. This is sort of the pros and cons that we have to be thinking about. So the substitution, like emicizumab and the rebalancing therapies I talked, the pros are sub-Q delivery, significantly reduced burden of treatment, steady blood clotting level. You can use this in children and adults. It has same effectiveness whether you have an inhibitor or you don't have an inhibitor. What are the cons? Well, we're probably not normalizing levels. And we know that for a fact now, that many patients, it doesn't completely rebalance the clotting system. I mentioned the thrombotic risk. All of those rebalancing therapies have had clots or excessive blood clotting observed in the clinical trial programs. So they have to use some risk mitigation to ensure that we don't overshoot on that rebalancing. You still need factor concentrate to manage bleeding events. And actually, most of the complications have come because of needing to still use a factor on top of the prophylaxis. And these all have an annual expense. It costs hundreds of thousands of dollars to treat every year. What about for gene therapy? Well, it has some promise, hopefully, of being a one and done treatment. It will produce steady state blood clotting, and the levels could be normal or at least in the mild hemophilia range. The trouble is, what about for eligibility? I mentioned the challenge of pre-existing immunity. We can't do this in children yet. I didn't actually tell you why we can't do it in children, but it has to do with the developing liver. If we're delivering these viral particles to a very young liver, well, when your liver divides, only your chromosomes are going to get passed on to the daughter cells, not the circular DNA from the gene therapy treatment. So as that liver grows, you will dilute out the transfected gene. So we really can't conceive yet how pediatric treatment is possible. Remember that gene editing I showed you, though. Since that gene editing is occurring at the level of the chromosome, your own genes, then a correction would be passed on to the daughter cells in the liver, and that would allow for a pediatric application. Lots of known as well as unknown risks in this therapy, and we still have uncertainty about the durability or the ability for redosing. So hopefully that gave you some hope about the promise that these offer. I hope I helped you understand that we shouldn't think of current standard of care as having no risks, because there's a real risk of continued joint deterioration as we age over subsequent decades, unless we get new and better therapies to the clinic earlier. Now that's balanced with some of the potential cons that we talked about today. So this is going to be part of how we interact with patients in the coming years. We'll be discussing these options, what these new tools offer, but I'm excited about the promise for the future, that we're going to be able to continue to improve outcomes for patients over the long term. So thanks for the opportunity to share with you today.
Let's see if this thing works. It's working? Hello?
Yep, we can hear.
Can you hear it? Okay,
Yep.
I got a mic. All right, so this is the question and answer period. Dr. Pike did an excellent job going through an amazing amount of stuff in a fairly short period of time. But if you have any questions, this would be the time to ask the doc. No questions? Sure.
First, I'd like to say thank you very much. It was very, very nice, very well done, and it explained the pros and cons. The question I have is the patient when they're doing the gene editing, it comes from the patient, or is it someone else can give that, and then it's like a autologous, or it's anybody can do that?
Okay, yeah, so there's different ways of doing the gene editing right now. We can use these vectors to deliver the gene editing machinery directly to the liver and correct the gene in the liver cell, etc. So we're not giving you anything other than the machinery to do the gene editing. But in other examples, we take your own cells, we edit them outside the cell in a facility, a lab facility. Those cells are corrected, and then those cells are given back to you. So I think that's what you're getting at when you're talking about autologous cells. Can you do this correction and get it back? Now, those are still a ways off. I'm aware of at least one clinical trial that's active up in Wisconsin and Milwaukee, where they are basically doing, they're taking a sample of your bone marrow cells, essentially. You do it through pheresis, but they edit those cells, and then they're given back to you. So it's your own cells that are given back to you. Now, the trouble is you still have to go through some form of an immunosuppressive protocol so you can safely receive your own cells back. But that protocol is active, and I believe the first patient is going to be dosed, or maybe it has already happened this month already. So we'll look forward to seeing how that strategy works out.
When you were pointing, okay. I will say, I don't know if you heard the presentation in Montreal, Dr. Pike, that there was 3 young men that they presented, one of whom had inhibitors and was in a wheelchair and very crippled up, and he got on the medic and was now a personal trainer and was a real success story in Australia. And there was another young man who had factor 9 with inhibitors, which has been kind of an underserved population, and he was on the clinical trial for Fatuzaran. And he also is not in a wheelchair anymore, and it's just like a miracle, another miracle here. So
yeah, absolutely.
Yeah, it's pretty amazing stuff. Any other questions?
Doctor, with all the information. So my question is how many kids over 18 already get that gene therapy, and are they really okay with them?
Yeah. So I think if I heard you said how many people have actually had gene therapy to this point. Thinking across all the clinical trials that I'm aware of, it's multiple hundreds of people with hemophilia around the world that have received gene therapy to date. In the trial that I mentioned that was submitted to the regulators for review, that hemophilia A gene therapy called Roctavian, there were 134 subjects in that trial. So you can learn a lot from having that many patients. There's a Heme B program that is also late phase, probably will also be submitted this year to the regulators. And it had 54 patients in that trial. Now that, that might not seem like a lot, but for a rare disease like hemophilia, and considering what trials have looked like generally before, these are not small trials. These are substantial numbers of patients. And I think they help give us confidence about whether these trials are reading out the results and whether they're going to be applicable if they make it to the clinics for commercial use.
Okay, I think if there are no other questions, I'm going to let Dr. Pipe go back to the rest of his Sunday, and thank you very much for taking this time off to join us here in California. And I hope you're having as nice a weather as we are currently here in San Ramon, California.
Yeah, well, yeah, thanks to all. I hope you have a great meeting together, and thanks again for the invitation.
Right.